Hi, my name's Ashley Mullins, and today I'm going to be presenting to you all my quality improvement project, which is on ER or emergency department wait times. To begin, we are going to talk about my quality improvement assessment and the three fundamental questions. Number one, what am I trying to accomplish? And that is a decrease of wait times in adult patients seen in the ER. By educating the community on differences between urgent care needs versus ER needs, I will be able to reduce the amount of low acuity patients seen at my local ER within 3 months. The article, Long Emergency Room Waits May Raise Risk of Death, reports on a study that investigated an operational standard to treat patients within the ER during a specific time frame and if long wait times directly impacted patient outcomes. The quote reads, "When the wait times rose to between 6 and 8 hours, the death rate was 8% higher than expected. While waiting 8 to 12 hours, the death rate was 10% higher than expected, compared with patients who were moved along within 6 hours. That meant an additional person died for every 82 patients delayed for 6 to 8 hours. Therefore, educating individuals is imperative to decrease wait times so that critical patients can receive the care that they need within a timely manner." The next question, how will I know that a change is an improvement? Change within 3 months will be an improvement when the community education that has been provided will attempt to reduce the low acuity utilization by patients seen within my local ED. And the third question here, what change can be made that will result in improvement, is the amount of education provided to citizens within my community. Another article I used named Patient Knowledge Impacts Use of Urgent Care, ED Services, talks about why people need to be more educated on the two different services. It was based on a survey's results of patients' knowledge of the two performed by CityMD. The quote reads, "Patients frequently had a difficult time deciding if they should go to the ER or urgent care center when presenting with non-life-threatening emergencies treatable in urgent care settings. For example, only 46% of respondents correctly selected urgent care as the appropriate choice for a scenario in which a child is presenting with 104-degree fever, shivering, and coughing. By implementing extensive educational events throughout the community, my team and I will be able to reduce the amount of low acuity patients seen in the ER, thus leading to a reduction in wait times and improved patient satisfaction within ED services." Next, we're going to talk about my PDSA, or Plan, Do, Study, Act. In the first component, plan, I will talk about these questions on the screen. What information is important to collect? And that is a baseline of how many low acuity patients are seen and treated at my local ER. Why is it important? Why should we care to change how long we wait in the ER? It's to improve patient satisfaction rates and, of course, reduce wait times. But it's also important to collect this data in hopes of decreasing mortality and morbidity rates with the patients visiting the ER. Who will collect the data? 3 other nurses and myself will collect this data to have a baseline of low acuity utilization within the ER. And who will analyze the data? It will be myself and another nurse. Where will the data be collected? It will be collected within my local ED workplace. When will it take place? The initial data collection would begin on the 1st of January, and then next, the data collection would be obtained again 3 months after education was distributed throughout the community. And how will the data measures and observations be collected? And this will be collected by observing the wait times with low acuity patients seen in the ER. The next part, do. Try the test on a small scale and carry out the test. We would do this by reaching out to colleagues and local organizations, such as churches or civic organizations, in order to implement education within the community on the differences between urgent care versus ER needs. Document the problems and unexpected observations. A problem that may arise is that colleagues or organizations may be unwilling to help. However, by educating them and the community on why these differences are important, will help reduce wait times to reduce the amount of low acuity patients seen in the ER. An unexpected observation would be difficulty keeping track of those low acuity patients seen in the ER during high peak wait times. And lastly, begin to analyze the data. My team and I would analyze the number of visits to the ER by low acuity patients with the data collected. Study. You will analyze the results, study the results, collect the data, compare the data, summarize and reflect. It's necessary to do this with this plan, and once education has been implemented throughout the community. 3 months after implementing education, my team and I would reassess the results found with the study. We'd hope to see a decrease in wait times and increased satisfaction with staff and patients. Also, there's a potential of seeing a decrease in mortality and morbidity rates in the results once education had been implemented. Without providing this imperative education to the community, wait times would continue to increase, and more low acuity patients would utilize the ER when it may not be necessary. This would lead to a decreased satisfaction with patients, increased mortality rates, and an increase in burnout of staff nurses. Lastly, act. Once data was evaluated after implementing education, my team and I would then redefine our next intervention based on the previous data collected. Although this project is not being carried out in real life, some modifications to this plan could be involving more nurses to collect data or implement education throughout the community, depending on the community's size and population. In preparing a plan for the next Plan, Do, Study, Act, or PDSA, there are some other measures I would hope to look at that could be impacting wait times within the ER. These would include patient satisfaction scores of the local ED, as well as morbidity and mortality rates related to those extensive ER wait times. These are my discussion questions I have provided to interact with my peers. The first one states, how do you believe people become misinformed on the difference between going to the ER versus an urgent care? And the second one is, what else could be impacting extensive ER wait times? How would you implement change on this problem, and would you believe that it is causing more of an impact on ER wait times? Which one? Low acuity utilization or your stated problem? Which one would be more of a priority to address? And in conclusion, change will be accomplished once education has been implemented throughout the community about the differences between what situations require a visit to the ER or urgent care. Once that education has been implemented, the community will be reevaluated in 3 months to identify differences from before and after education. From this, my team and I would hope to see a major decline in the number of low acuity patients seen in the local ER to reduce those wait times tremendously. Also, my team and I would hope to see an improvement in patient satisfaction and mortality and morbidity rates within the local ED. We would include these changes in our next PDSA to analyze. Without implementing these interventions into the community, wait times would continue to rise, and the amount of low acuity patients seen would also increase, thus leading to more deaths and decrease satisfaction with both staff and patients. And here are my references, and thank you for your time. That's the end of my presentation.